Yes. So I'll speak about laboratory testing in a resource-constrained environment. In the real world, what is happening now. To begin with, I'll apprise you about our institute and our CML patient that we see at our institute. The city of Chandigarh is situated about 270 kilometers north of New Delhi, that is our capital city. And patients come to our institute from the states of Punjab, Haryana, Himachal Pradesh, Jammu and Kashmir, the northwestern Indian states. And they also come from Uttar Pradesh, Bihar, and other eastern states and the far eastern states as well. And they pretty much come from rest of the India as well. PGIMER Chandigarh, our institute is an autonomous institute funded by the central government. The patients who come to our institute, they get free treatment or the treatment is very heavily subsidized. 10 years back, our institute had about 1,700 beds, and last year the number was 1,948. The attendance in outpatients recently was about 2.8 million, whereas 10 years back it was about 1.5 million. The indoor admissions last year were 98,512. Adult hematology services were started in 1982. Imatinib was started to be used since September 2001. Our institute is one of the GPAP or NOAA centers in India, and more than 2,500 patients are on follow-up. The breakup of CML patients diagnosed in 2020 is as follows. Chronic phase patients 150, accelerated phase patients 21, blast crisis patients 30. This table just shows you the kind of manpower we have. We could do much better with more manpower in terms of faculty, the residents, and the technical staff. Right now, we are very much understaffed, keeping in view the patient magnitude at our institute. CML is a model disease, and the story of CML and Philadelphia chromosome has taught us so many lessons, and we continue to learn from it. The question that we face now is that how do we monitor translocation 922 or BCR-ABL1 transcripts so as to benefit maximum number of CML patients. The accurate and standardized molecular monitoring of CML patients is an integral part of disease monitoring. Deeper the molecular response, better for the patient and the treating physician. So what about CML patients in our institute and rest of the India or any other resource-constrained environment? CML is the commonest hematological malignancy in adults. They've come to us at a much younger age. Patients present in advanced stage of disease. There is higher prevalence of hepatosplenomegaly. Most patients respond to imatinib. More than 90% of the patients remain in chronic phase, and 4 to 5% of the patients transform to accelerated phase or blast crisis. The significance of previous therapies, bone marrow fibrosis, remain unknown at present times. RT-qPCR and kinase domain mutations are not very well studied in most of our patients. In this table, I wish to show you the lab practices in a few of the Indian institutes. At our institute, we see about 200 patients per year. More than 2,500 are on follow-up, as I mentioned earlier. We perform CBC, bone marrow aspiration, biopsy, cytogenetic analysis, FISH, RT-PCR, being done since 2010. Gene experts started in 2013. KD mutations earlier were being done on a research mode. Now they are going to be started for diagnostic purposes, routine practice. We have the DDPCR machine, but the BCR-able IS kit is not available. So the machine is being used for other disease monitoring, not CML. At Sister Institute at Delhi, they perform RT-PCR, RT-qPCR. At Tata Memorial Hospital, Mumbai, FISH, RT-PCR, RT-PCR, RT-qPCR for BCR-able is performed, KD mutation by Sanger and NGS, and flow cytometry for lymphoid blasts. At Tata Medical Center, Kolkata, they perform CG, FISH, RT-PCR, RT-qPCR for BCR-able, KD mutations, flow cytometry, and they perform DD-PCR for BCR-able 1, P9T transcript. And they also run a myeloid NGS panel for their CML patients. At Hyderabad, CBC, bone marrow aspirate, biopsy is performed, FISH, RT-PCR for BCR-able, all three transcripts is performed. Cytogenetic analysis is outsourced. Coming to the center at Far East in Manipur, CBC with the peripheral smear examination is done, routine biochemistry, viral markers, bone marrow examination is done. RT-PCR, RT-qPCR, and IRMA are outsourced. So you can appreciate that there are varied kind of facilities available at different institutes in different parts of the country. According to the information that I received from Max Foundation, there are 11,711 active CML patients in India who take treatment in 259 institutions. It is usually advisable to get BCR-able 1 test done twice a year. However, since most of our patients come from low socioeconomic background and cannot afford BCR-able 1 test, most physicians recommend getting at least CBC done. Few centers only accept in-house tested reports while others accept outsourced reports. The information that I got from Safir India tells me that there are 6 institutes in India, Max Foundation affiliated centers, where gene expert machine is available, including our institute. According to recommendations, the monitoring of CML has to be done according to the hematological response, cytogenetic response, and molecular response at frequent and certain intervals, regular intervals. The critical milestones have to be achieved while on therapy, so that we can ascertain whether patient is showing optimal response or there are any warning signs or there is failure to treatment. In this very elegant article in Blood 2018, Shanmuganathan and Professor Tim Hughes have asked a very pertinent question, very close to my heart, that during molecular monitoring in CML, how deep it should be, how often it has to be done, and how should it influence therapy. The profile of patients in resource-constrained environments, how is it different? So if patients are economically privileged, they can afford to have best of diagnostic and monitoring facilities. And if they are economically underprivileged, then they need to reach a place like our institute where treatment is free or heavily subsidized. But most patients find it difficult to reach a hospital. I'm going to share the story of a typical patient with you who comes from this kind of a background. So this was a 30 years old female patient from Bihar, which is 700 miles from our institute. who was diagnosed as CML chronic phase in January 2016. Spleen size was 20 centimeters. CBC showed anemia, very high TLC, and thrombocytosis as well. Blast percentage 5%. So according to the CBC and the bone marrow examination, the morphological diagnosis was CML chronic phase. Bone marrow cytogenetics revealed 100% Philadelphia positivity. B3A2 BCR-ABL1 transcripts were shown by RT-PCR. RT-qPCR could not be done because patient could not afford it. The paperwork for GPAP program takes about 4 weeks. So ultimately, imatinib was started in April 2016 for this patient. So how frequently CBC is to be done? This patient came from Bihar, 700 miles away from our institute, and there's no proper medical facility nearby, near this patient's place. So CBC could not be done at the recommended intervals for this patient. And this patient's spleen size was 20 centimeter versus 5 centimeter in a typical chronic phase, early chronic phase patient. At 3 months interval, patient achieved complete hematological response. At 6 months, repeat bone marrow cytogenetic analysis showed Philadelphia positivity 45%. At 12 months, Philadelphia positivity 25%. So that means that cytogenetic response wasn't achieved. So how frequently bone marrow cytogenetics has to be done? In India, we like to do it at diagnosis, and later, when do we do it? So earlier practice at our institute was that we would do it at diagnosis, then at 6 months, then 12 months, then 18 months, and so on. Currently, because of the heavy increase, ever increasing patient load, we have resorted to doing bone marrow examination for cytogenetics at diagnosis, and then we try to do it at every 12 months interval. We charge about rupees 500, which is converted, we can say is equivalent to about $7 US. But since cytogenetics is a time-consuming technique and the patient load is very high, it's difficult to keep up with it. So what next? This kind of patient hasn't responded to imatinib. So we continue the same drug, and we possibly would like to increase the dose of the imatinib. So dose was increased to 600 milligrams per day. For 18 months, there was no follow-up. 24 months, CHR was present and bone marrow showed 25% pH positivity. Patient did not come back for follow-up as patient was taking imatinib 300 to 500, 300 or 400 milligrams per day. So then RT-qPCR was done gratis, and the levels of transcript are at 30 months, it was less than 0.05%, at 36 months, 0.8%, 40 months, 6.4%, 45 months, bone marrow examination was done, which showed blast crisis. There was Philadelphia positivity, and there was additional cytogenetic abnormalities in the form of double PH chromosome. So there is a very impressive body of literature to drive home the importance of standardization of RT-qPCR. I'm not going to read out all these articles. So the diagnostic and monitoring issues which are unique to our kind of environment, patients come from very far away places, and because of economic reasons, they are not able to adhere to the recommended follow-up schedule. There is very often late diagnosis made, and which means that there is higher leukemia burden, as was evidenced in our patient. The blood counts, the bone marrow morphological diagnosis is available to most patients. Cytogenetic analysis being an invasive procedure, time-consuming technique with a longish turnaround time, and the availability and standardization are issues. So expertise also is not available at most of the centers. Fish is not widely available and is not good for monitoring. Molecular analysis, again, there are issues of availability and standardization. International reference material is not available as yet. About 95% of the CML patients receive imatinib from GPAP or NOAA program. KD mutations are not done in many patients because of the issues of availability and standardization. There are so many kinase domain mutations which can be detected, but how many of them are relevant to therapeutic decision making? That's a question to be pondered over. Second generation TKIs are too expensive and cannot be used in most CML patients in developing countries unless they are made available free or at subsidized costs. Less than 5% of our patients receive second line TKI as first line therapy for CML chronic phase. More than 90% receive second line TKI in accelerated phase and blast crisis. And it all depends on the financial affordability as patients pay from their own pocket. And this information was shared by my colleague, Dr. Malhotra. So I would like to make some suggestions to International CML Foundation that more preceptorships may be offered to diagnostic hematologists so that they can come back to their institutes and improve the diagnostic and monitoring facilities. Reverse exchange programs should be implemented so that doctors from the developed countries may visit centers in developing countries. And by doing that, they might be in a better position to appreciate the situation at ground zero. RT-qPCR monitoring, there is a need for a user-friendly technique. Standardization as per international norms is not easy. So I keep thinking that would a cheaper cartridge-based CML monitoring strategy be a better option? And we are likely to hear about other options along the same lines in the subsequent presentation. Second generation TKIs may be made available free or at subsidized cost. Keola et al. Way back in 2011 published this paper in Hematologica, and they mentioned that the expert BCR-able monitor assay could be appropriately used in a near patient setting for routine quantification of E13, E14, A2 transcripts, preferably in partnership with a regional reference laboratory. Our experience with GeneXpert is that the machine was donated by Sahayata Charitable Welfare Society and installed in our department in July 2013. We are the first medical institute in the country to get GeneXpert machine dedicated for the treatment monitoring of CML patients. We published our experience in clinical lymphoma, myeloma, and leukemia 2015, and we found that BCR-able assessment at 3 months is superior to assessment at 6 months. Patients with CML in the chronic phase who achieve CHR within 6 weeks are more likely to achieve BCR-able less than 10% at 3 months and less than 1% at 6 months than patients who achieve CHR between 7 and 12 weeks. So I have this question in my mind that GeneXpert being such an easy, accurate technique and with a fast turnaround time, why it is not so popular. And I think there are some reason to that. So I would end with acknowledging the help rendered by the faculty, resident, and staff of our hematology departments. I'd like to thank the other 5 institutes named here who have given me the information about lab practices in their hospitals. Max Foundation and Cepheid India for information about their programs and the machines. And finally, a big thank you to ICMLF Knowledge Center for making me part of this wonderful endeavor. Thank you very much.